Hello everyone, it's a pleasure to be here in my friend's Felice Darko YouTube channel to talk a little bit about a subject that is very dear to me, the neuroimaging for selection of stroke patients in the late window. Thank you very much, Felice, for the kind invitation. So let's start this presentation with an overview. Let's talk a little bit about the context, why does selection matter, how to select patients in the late window, and finally the perspectives. So, stroke is the second main cause of death worldwide. Almost 9.5 million people are touched by this disease every year. And we know that mechanical thrombectomy is one of the best treatments available in medicine right now, with a number necessary to treat of 2.6. So why select? Although any treatment in medicine is subject to side effects, the idea is that the benefit to the patient should always outweigh the risk. So we studied that in the first year of medical school, primum non nocere, and we should always keep this principle in mind. So we should select to avoid unnecessary treatment and not to exclude patients who would benefit from therapy. What are the goals of neuroimaging in stroke treatment then? First of all, we should rule out bleeding, and the non-contrast CT is up to 100% effective for that. And then we should rule out stroke mimics, tumors, seizures, and so forth. We should always assess the extent of ischemia, so the core, that is the irreversible tissue that has already suffered, that will not be saved if we reperfuse this patient. So if we use a non-contrast CT, we can use the aspect scale, and sometimes we can think about using the net water uptake. And as well, we should assess the presence and extent of the potentially savable tissue, what we always call penumbra. And then this estimation of core and penumbra are different if we're talking about the early window, so in the first 6 or 7 hours after the deficit, or if we're talking about the late window, that would be 6 to 25 hours after the stroke onset. So if we talk about the European guidelines, they state that patients should be treated with mechanical thrombectomy plus best medical management up to approximately 7 hours after stroke onset without the need for perfusion imaging based selection. So if you talk about the late window, we should keep in mind that, of course, time is brain. 1 minute of brain ischemia can kill many neurons in the middle. We think about something of 2 million neurons each minute, or 12 kilometers of axons. So we always talk about this time window. But we should keep in mind that nowadays imaging is brain, because tissue is the issue. Each patient has different characteristics, and imaging is mandatory nowadays, that we try to tailor a little bit the imaging protocol and the treatment for each patient, because we're now in the era of personalized medicine. So nowadays, we have not only to consider the time window, but also the tissue window. So let's go with some examples. Now we have a 69-year-old female patient with an NIH stroke scale of 23. She came with a large vessel occlusion, proximal right M1 occlusion, and she did not have a hemorrhage in the non-contrast CT. She was reperfused quickly with a very good reperfusion of a ticket 3 in less than 3 hours. And in the 90-day modified ranking scale, she had 4 points and a large ischemia, residual secular ischemia on the right cerebral hemisphere. On the other hand, we have a 67-year-old female patient with a similar NIH stroke scale that was also submitted to a CTA. But now we see that this patient has better collaterals, and she had also an MRI that shows the core. And in the opposite to the previous patient, this one was reperfused after 12 hours with a TK2B. And we see after the 90-day evaluations that the NIH stroke scale is only 4, but in the MRI we can see that she has a much smaller core, final core. and we can attribute that to the presence of good collateral. So nowadays we know that the outcome is directly proportional to the collaterals and inversely proportional to the time. So in the ESNR meeting of last year, we saw this presentation that I considered very interesting. This colleague, he showed us a case of a patient that was 74 years old that presented herself in 2002 with a carotid T occlusion, and at that time there was no mechanical thrombectomy. She only received intraarterial TPA, and she did not had an efficient correct recanalization, only with medical therapy. And then she had an MRI, a diffusion weighted image, after 3 hours of the stroke onset, and we see a small core on the left on the posterior branch of the internal capsule, and after 27 hours we saw that this core was still growing, and it kept growing after 5 days of the initial symptoms. So we see very clearly in this example the progression of the core, even though she was largely after the first 24 hours. And then we have some other papers that show us very clearly that there are two different profiles of patients relative to the progression of stroke, the progression of the core. So we know that most patients, more or less 85% of the patients, are slow progressors that obtain their final course very in a much larger time from stroke onset, and only a few of the presenting patients are effectively fast progressors. So most of the patients are patients that are eligible to therapy in a late window. And nowadays we consider up to 24 hours because this is what is available and it's supported by the literature, but maybe we will in the future think about something after 24 hours and even more, pushing the boundaries each time more. So we know that depending on the collaterals, these patients, if they have more collaterals, they will be slower progressors and they will lose less neurons per minute with a lower infarct growth rate. And this tissue with more collaterals is highly resistant to ischemia. And on the other hand, the fast progressors are the patients that have less collaterals and that then will lose many more neurons per minute and are much less resistant to ischemia. So this paper has elegantly demonstrated that based on the initial core on diffusion weighted imaging, we can predict the velocity of the progression of the stroke. So patients that present themselves with a smaller core are most of them slower progressors, and on the other hand, patients that present themselves in the early window already with a large core are patients that very probably will progress very fast and that would have less benefit to be treated in the late window. So this is another very illustrative diagram that shows the same thing, that overall the impact of time is lower in patients that have more collaterals and are slower progressors. So as I said before, nowadays we're not only talking about the time window, but we should keep in mind that we should absolutely think about the tissue window in the era of precision medicine. So this is a case report that I think that is very interesting, that has demonstrated the benefit of a very late thrombectomy after 6 days in this patient. She was a 75-year-old woman with intermittent left hemiparesis for the past few days that sought medical care with facial paralysis, and in the beginning she only had an H stroke scale of 1, and the CTA demonstrated a proximal M1, right M1 occlusion. And then after an initial period of stability, she progressed her symptoms on the 6th day, She had a worsened neurological status with an NIH of 10, and then at that time CT perfusion demonstrated an area of penumbra, and then the decision was taken for the mechanical thrombectomy. This patient benefited from the treatment, the interventional treatment, and then she had no complications, no hemorrhagic transformation afterwards. So, as I said, pushing boundaries. So in this case, if these neurologists and neurointerventionists had followed the current guidelines, they would have excluded a patient that would benefit from therapy. So another example, this patient, a 64-year-old female patient, and the second day after cardiac surgery, she presented herself in an intra-hospital stroke with right hemiparesis for 8 hours, and advanced imaging CTP showed that there was no mismatch between core and penumbra. So this is a patient that would not benefit from treatment. So in this case, we should avoid unnecessary treatment. This is not a patient that would have a benefit from the intervention, and on the other hand, she could have complications as bleeding if she was treated in a interventionalist way. So how should we select? Imaging selection protocol should be fast, should be easily implementable, should be reliable, with few contraindications, and overall safe, offering the patient the best chance of a favorable outcome. So what are the advanced methods that nowadays are available? So less available is MRI, is diffusion weighted imaging. It has a lot of contraindications. It takes more time to transport the patient from the emergency room to the MRI machine. And more available, we have the CTP. So both search the target mismatch profile to consider the patient or not to proceed to mechanical thrombectomy. So what we have now as the current guidelines, we have the American and European guidelines. The American guidelines are based on two very important studies. There are the DAWN and the Diffusion 3. There were very important papers published on the New England Journal of Medicine that changed the world guidelines. There are trials that are proof of concept, and they have very restrictive criteria because they wanted to show that mechanical thrombectomy was effective. So if we think about the pros of MRI, diffusion weighted image is the gold standard for assessing ischemic core value. It has no ionizing radiation, has increased sensitivity for posterior false strokes than CT, and gives important answers even without contrast injection. And we can think about an optimized MRI protocol that would take only 6 minutes and give us very important answers. But on the other hand, it's a less available method, it's more expensive, it uses the magnetic field, so it's not compatible with metal implants in unconscious patients. We have difficulties in monitoring these patients during the examination, equipments may not be compatible. This is a method that is very susceptible to kinetic artifacts, and if we consider the angio MRI, it's a less accurate method than the angio CT and requires different acquisitions of the extra and intracranial vessels. So on the other hand, CTP is widely available, very fast, gives more autonomy to the neurologist and to the interventionalist, and it's validated by the major trials. But we should remember trials that had very restrictive criteria and that had ultra-selected and cherry-picked patients. Okay, so if you consider the cons of CTP, it has high radiation dose, it's susceptible to motion artifacts, it's only a time snapshot, it's not the long film, it depends on the heart function and the blood pressure. It sometimes has controversial selection of the appropriate threshold. It has sometimes longer processing times if we don't have the specific softwares. And we should keep in mind the lack of standardization, differences in the post-processing software and algorithms. tissue may be hypodense at non-contrast CT, but if reperfusion has occurred spontaneously, there may be no perfusion deficit. We should remember the impact of the extracranial stenosis with the hypoestimation of the core and hyperestimation of the penumbra. We should keep in mind that previous strokes and vascular leukoencephalopathy may confound the results, and overall, it can overestimate the ischemic core, leading to exclusion of patients who would benefit from treatment. This is very important, this is cardinal. So there are many papers that talk about the ghost infarct core. So what it would be if the patient comes in a very early window and does CTP, sometimes the software considers that the core is larger than the final core. So it overestimates the real core, the final core, and we should keep in mind that based on this, we can exclude patients from mechanical thrombectomy, patients that would benefit from treatment. So this is a paper that I like very much. It's a little bit old right now, it's from 2015, but it has a conversation between Stanford and Harvard neuroradiologists, and it points very in a very instructive manner the pros and cons of CTP and MRI. I recommend this paper to you that haven't read it yet. And what I would like to point is that one of the arguments of the Harvard colleagues is that a core can be less or more evaluated according to the uncertainty that CTP poses. So a core of 70 milliliters could actually range from 11 to up to 124 milliliters. So that's a very important difference. We could underestimate or overestimate the core in a very important manner. So I recommend you this paper. And based on all that, what should we do? How should we select patients for mechanical thrombectomy in the late window? So nowadays there are more recent papers that show the impact of the CT and CTA approach for the decision. Maybe a simpler approach would be a better approach for most patients. We know that there are discordances between the CTP and multiphasic CTA, and CTA is a criteria that would exclude less patients that would benefit from treatment. So if we take a look at these graphics, I recommend this paper as well. We see all the patients that are represented in gray that had proximal LVO, and patients that were selected by CTP are represented in purple, and patients that are selected for treatment by the MCTA criteria are selected in green. So you can see how different in the circles is the selection for the treatment, and how many patients that would benefit from treatment can be excluded if we use the CTP approach. So this is a very interesting map that if we look very quickly, we can think that it's the lower row, the CTP map, but in fact it's a map that is generated from the multiphasic CTA. And we see as well that for the less experienced observers, we have some softwares that may put different colors in each phase of the multiphasic CTA, like A in red, B in green, and C in blue. And it would help less experienced observers to make the difference of each phase more quickly. So it's a simpler approach, and it's being showed more and more effective as an approach to exclude less patients from the intervention. So more recently, we have this very important paper, in my opinion, that has a great number of patients that show us that the simpler approach with CT only paradigm and not using CTP, not using MRA, may be very interesting and maybe enough to select patients in the late window. So this is the third paper I recommend you to read after this presentation. So what are the perspectives? So as I said, a simpler approach may exclude less patients from treatment, may improve the outcomes, and we should think about the use of artificial intelligence and the help that machine learning and deep learning can provide us in the fast interpretation of our data. So we have some groups that are working very hardly on this, about the softwares that can help us to choose informed and more automated decisions for the eligibility of endovascular treatment for patients with acute ischemic stroke using CT. And we have seen some very interesting approaches on this. So as this paper shows, a machine learning based MCTA score and model is able to predict brain tissue perfusion abnormality and follow-up infarction comparable to CTP. And we should not forget there are other approaches that are being studied right now. So We Trust is a study that is recruiting patients in order to analyze the possibility of the optimization of the workflow for patients going direct to angio. And this has already been commented by Dr. Marius from Switzerland, that this direct to angio would reduce in more or less half an hour the needle time. So the patient could receive treatment more properly and in a faster way if we can, for selected cases, skip the diagnostic approach, the classic diagnostic approach with CT and CTA, and go maybe directly to the angio suite. And we should remember as well that there are other trials going on that are analyzing patients with larger core and low NIH stroke scale. We have already some very interesting preliminary results, like the Tesla, Tension, LEST, EndoLow, MOST, and MRI clean late trials. We should keep track of the results of these trials. So as take-home messages, the question is no longer who to treat, but in fact who not to treat. Neuroimaging, think about it, less is more for stroke and even in the late window. So go open the vessel and leave no LVO left behind. I hope this has been useful for you, and if you're interested in this subject, this is another paper that I would recommend you to read, The Artificial Intelligence in Cold Stroke, Paradigm Shifts. Do radiologists really need to change their practice? This is a very thoughtful paper from Dr. Vagal and Dr. Saba, and with this, I thank you very much for your attention, and I remain available through social channels and media for questions, and thank you very much once again.